Hi, group. This week we're all talking about something we've probably all seen in our clinical practice at one time or another, unfortunately, and that's people who are involved in some kind of opiate or narcotic substance abuse. Some of the assessment findings that you see in this situation are, sometimes it's the symptoms of actual overdose, being respiratory depression, pinpoint pupils, and all these central nervous system depressant effects, urinary retention, constipation, and that type of thing, constant opiate use, where the opiate receptors, the mu and the other two, just kappa and delta receptors, are being constantly stimulated by the opioid, which causes the central nervous system depression and the low motility of your GI tract, your GU tract, and also stuff like the pinpoint pupils. Some other things that you see in situations like this from the patient's behavior standpoint, and also, just these types of assessments that we do, is we want to look for stuff like doctor shopping, where a patient has multiple scripts from multiple doctors, patients losing their medications, patients claiming only this one thing ever works for them. If anybody works in an ED, which my husband does, he sees a lot of people coming in, oh, I hurt my toe, I need some Dilaudid kind of behaviors that indicate that a person probably does have a problem with substance abuse. There's a lot of indicators and things that make people more likely to suffer from substance abuse, and all these are in our text. And one is chronic pain. There's a paradoxical effect sometimes with chronic pain, that the more once you get to a certain point, the more opiates you take, the less it helps your pain. So you can end up with some substance abuse issues from that. Homelessness, joblessness, unemployment, poverty, and these psychosocial issues can also lead someone to be more likely to abuse narcotics because of those types of issues. And also, it induces a state of euphoria. And once you've experienced that, it's difficult for some people to not want to continue to seek that feeling out, which is in some cases understandable. So, as healthcare providers, we have a responsibility to ensure that you have good stewardship with our narcotics. One of the ways that we do this is by utilizing mixed drugs, where there's a narcotic and another type of pain reliever, like an NSAID. Another way we're doing that is to not be prescribing extra medication, prescribe just what the patient needs, just the smallest dose that the patient finds relief with, and also to use the adjuvant methods of pain control and other non-pharmacological methods. I think we can advocate as nurses for more use of these types of pain control methods with our providers that we work with, instead of just quickly writing a script for something just because the patient says they're hurting, not exploring other avenues of pain control. In my clinical practice, in a way it's unique, as it is in other ways, because we have very long-term sedated patients. So we have a lot of substance abuse prior to admission, because we get a lot of meth lab explosions. We get a lot of people that are intoxicated in some way and either make very poor decisions that cause themselves to be burned, or they pass out and with a cigarette in their hand and set their house on fire. It's a very common place for us to see these types of things. So we have a lot of our patients that are have histories of substance abuse. We also have people that don't have any history at all but spend 8 months on a ventilator on methadone and Ativan around the clock. And we can have some issues weaning these people off those medications. We have a very careful, very comprehensive weaning protocol for getting people off of the sedation and pain medications. We do not discharge anybody that requires more than just a token dose of oxycodone for a dressing change. For our long-term patients, we typically don't discharge them until all of their wounds are closed. They need no wound care at all, and they're not requiring any pain medication for any of their therapy beyond stuff like for chronic nerve pain that we continue to prescribe frequently throughout the patient's life, like Lyrica, gabapentin, and NSAIDs. So we do this by having a lot of physician buy-in to the weaning protocol. We also do this by having a lot of social work support both during the hospital stay and lifelong burn survivor support after the hospital stay. We have multiple support groups all around the state that are tied to the J.C. Burn Center that help burn survivors cope with the unique challenges that they suffer in the community afterwards. And one of those things is chronic pain and risk for substance abuse. We have retreats and education year-round for burn survivors and providers to burn survivors outside of a burn center that talk about these issues, and that they're frequently issues that a burn survivor struggles with forever, because the pain doesn't necessarily go away just because the wounds are closed. So it's a pretty interesting issue for us from that perspective, and trying to avoid debilitating addiction related to an injury that really did truly need the medication. So it'd be interesting to hear how you guys deal with substance abuse in your practice, and looking forward to your videos. Thanks.